unit. And so I'm going to share out just a little bit holistically on what it is, how we kind of landed upon it, and then share like we did in the breakout rooms around our sustainability model for continuing on. It's a pretty costly annual program. Um, so essentially, kind of the origin story for us behind Mobile Crisis. So back in 2017, the Solano County Prevention Committee, headed by Solano County Behavioral Health, put together a suicide prevention plan for the county. And in there, based on a lot of youth feedback and family feedback, the groundwork was laid that there was a desire for school-based crisis response services that were specialized to the needs of students and school communities. But of course, there was no funding attached, so it made its way in there as part of the plan with the hope that we'd be able to lift it up when and if funding came before us. Then in 2019, we found that we were getting a lot of feedback from our school districts that 5150s were increasing. They were having to bring in law enforcement, not ambulances, to respond to even more mental health crises than they ever had before. So right around that time, that's when MHSSA released, I believe it was their second round of funding. And we thought, well, this is an opportunity to apply and see if we can bring this into fruition. And so we applied based on the 5150 data at the time. We thought that we would have between 45 and 60 crisis responses annually to the schools with the data that they had shared with us. So we put that into our MHSSA grant. Of course, the pandemic hit around March or so of that year. And I can remember during the first weeks sitting at home teleworking, receiving the notification that our grant had been approved for this wonderful mobile crisis program, even though we were all sitting at home. That was great. It gave us a year to really iron out our plan and our model and what that would look like and collaborate to get our school districts on board so that when schools opened in 2021, we were ready to launch this new initiative. Really side by side at the same time, our community-based mobile crisis, which serves the whole community, was also being launched. So it was a really nice pairing to say you're going to have the whole community for those moments when a young person is at school in need of supports. SCO is going to be able to step in and provide that. And then what we found with the pandemic, that 45 to 60 annually, our very first year, we responded to 252 youth, not including all the ones that we were so bustling that we had to say we can't respond. So you have to call law enforcement or community-based. So the need was far greater than we even anticipated it would be, and has continued to be. We near out around nearly 300 responses annually, 6 years in. So just a brief walkthrough of what Mobile Crisis looks like for us. So this is essentially our hub. We have like a shared space where everybody sits. It's really important for us to, calls are continuously coming in. So to be able to see, is our case manager out for lunch right now and not able to answer? Does somebody else need to pick it up? Is somebody doing an intake? The hub is a really kind of lively part of our office. But whenever there's a suicidal or homicidal young person at one of our 96 schools that we could potentially respond to, we respond to all public and charter schools within Solano County, elementary, middle, high. And so a call will come in, we do a triage right then and there on the phone. It takes about 10 minutes just to assess for, is it appropriate for us to respond? Is it immediate? Where we're telling them to call law enforcement if there's an immediate concern around safety of the young person and if they're in a homicidal space towards others. Our goal is to wrap that up within 10 minutes, respond to schools within 30 minutes. So they're centrally located in Fairfield, which is really kind of a center hub for Solano County. And we ideally are able to respond within 30 minutes. We respond to Rio Vista, which sometimes takes us a little bit longer because it's just a bit more of a commute. So we get out to the site, doing this. One of our clinicians will be doing an assessment, really meeting with the young person, meeting with the family or contacting the family to get information from them, meeting with the school site. We have a very collaborative approach if we want to know what has been researched in the past week on a young person's Google Chromebook, for instance. We get fed that information to help go into our assessment process. And so then we either assess that, yes, we think we can stabilize this young person and connect them with resources today. And we have either an intern or a case manager present with us that starts doing that. Or we don't think that we can safety plan. And then all of our clinicians are 5150 certified. They'll write the hold. We contact Medic Ambulance. County Behavioral Health has a contract with them, so we're able to tap into Medic. Coming onto the site, we've gotten really good at working with school sites where it's not Medic coming into the front of the school during passing time, but how can we, as confidentially as possible, get this young person onto an ambulance and where they need to go for further assessment. And then we have brief case management afterwards, and I'll speak to how we're hoping to even extend that model a little bit more. But outreaching to the families just to ensure that the young person is connected to the resources that they need. And if they've been hospitalized when they get out, also supporting them with some transition back to school. So important to highlight all of the partnerships that really need to work together on a near daily basis to make this happen. Some entities like in red that we didn't realize, like we have one very small community where fire almost always responds with law enforcement. It's just the nature of their small town. And so we weren't anticipating that in the beginning. And so how can we have fire know that in these types of cases, really no need for response to kind of keep the confidentiality preserved. Dispatch centers at school, schools were accustomed to calling 911. So to switch from calling 911 to calling into the local COE to receive this type of support, took some navigation with our dispatch centers in the beginning, but for the most part, it's been ironed out for a number of years. So initially, as I said, MH Mental Health Student Services Act funded us for 5 years. We had a little bit of extended kind of carryover money that carried it beyond that. So it's a $1.5 million annual operation, essentially. So we have 7+ staff, plus being kind of our interns. I'll speak to when we started integrating interns and the why behind that. And I think I misspoke before. It's actually 98 schools that we respond to. So during our first 5 years, when we were under Mental Health Student Services Act with our contract through County Behavioral Health, we became a certified Medi-Cal billing site, and we're billing to EPSDT for our crisis, collateral, and case management services. As we realized we needed an additional clinician because of that expanded number of young people, County was able to support us with some PEI funding to bring on another clinician. And then this past year, to gain a higher rate than the EPSDT rate, we've switched to having access to the specialized mobile crisis encounter code, which is about $2,000 per encounter. So about a 2 to 3 hour response we can draw down for those Medi-Cal students, about $2,000. But that also required us to shift our model. It used to just be one clinician responding at a time. To receive that encounter code, you have to respond in pairs. And that's when we tapped into a pretty robust clinical intern program. And so we, this past year, started to place 2 of the interns on the mobile crisis team. So they act as that second responder when they're not available. We have case managers that will co-respond so that we can receive that increased code. But now with MHSA, BHSA sunsetting in light of Prop 1, County Behavioral Health, of course, their coffers are, as many of you are probably experiencing with your county behavioral health partners, the cash is not flowing as freely as it once was for them. So we're having to look at, we know we want to keep this program, we need to keep this program, but we can't be reliant solely upon county behavioral health. So the plan that we've been enacting, working with consultants on how do we tell the why and tell the story from a fiscal picture so we can really get buy-in for the whole community, is looking at a collaborative share of costs. On that prior slide, all those community partners, how do we tell our school district partners, here's how many we've served. This is given these administrators or these school psychologists time back in their day. Law enforcement, certainly SROs were heavily relied upon before. We've given them a lot more time where they can just focus on what they are expert in, and not having to run suicide crisis assessments or transporting young people in the back of police cars to emergency rooms, talking to our board of supervisors, city board of supervisors, looking at our emergency rooms. So we have about an 80% safety planning rate with our young people. So whereas it used to be a school site saying, we're concerned enough that we're contacting the SRO and doing a transport, or calling parents and saying, we want you to pick your child up and take them to the local emergency room. 80% of the time, we're realizing we can actually safety plan, wrap this kiddo in services, and only 20% of the time does it elevate to where we feel like we need to complete the 5150 and send them in. And at that point, we've written such a robust 5150 that even the emergency room staff can be pretty reliant that where we've landed, this young person's going to need some at least short-term hospitalization. So really giving a lot of time back to our emergency rooms and cost savings and not having the young people sit in space waiting to ultimately be sent back home at the end of the assessment. So we're telling that story to really get that collaborative approach. Our intention is to use the fee schedule for reimbursement when we can for those case management and collateral services with our case managers who are also certified wellness coaches. And then we were recently given a grant through Path Cited for enhanced care management. We have a contract with our partnership health plan and to leverage funds through them also for that ongoing case management, which we've never been able to provide before. So now when we get a Medi-Cal kiddo, being able to tell the family, we can actually hold you beyond just a period of 1 to 2 weeks and hold you in kind of monthly support with this case management to meet the more holistic ongoing needs of the young person. And so braiding and blending, as Michael Lombardo always encourages us to really lift up. As I said, it's a costly program, but also very cost effective when you look at it. And that's a little bit about Solano County's mobile crisis team.